So, hi guys, my name is Mary Rossio, and I'm with Lightways Hospice and Serious Illness Care. Some of you may know us we were formerly Joliet Area Community Hospice. So we've been serving the community for the last 40 years, but we've really expanded the communities that we're helping. So we went from one community, Joliet, 40 years ago to 11 counties. So we're all the way out here in Aurora. We go out to LaSalle, we go as far south as Livingston, up to Lake County and all the way over to the Indiana border. So we really cover a very large population for our serious illness care as well as our hospice care. So I just wanted to, some of you that may seem like it's a unique name or a new name, that we're actually have been around for quite some time. And I wanted to start too, that I want this to be a safe space for everybody. So if I say something and you have a question about it, maybe you're not comfortable asking me or putting it in the chat box, please know that I can hang out after, or I'm going to leave my number and you can call me when you're the most comfortable to do so, because I want to respect everybody's current situation or maybe even past situation. I also want to make sure that if I trigger something, maybe you've had a recent loss, please know that we have grief support that will help the community as well. But it's also okay to step back and reach out to me later. Okay. So I want to talk a little bit about hospice and serious illness care and the role that we play. For hospice, it's for someone who has a terminal illness. So it's considered a CTI, which stands for Certified Terminal Illness. A physician is who deems you with your CTI or deems you with a certified terminal illness. So someone for hospice usually has a prediction, the key word there is prediction, from a doctor that you have 6 months or less to live. Now, some of our patients we've had on for a year plus, because maybe their diagnosis or their disease process took a different path than expected. And we still welcome that. We still want to care for them. And you can still qualify for that hospice benefit. But typically it has a 6-month time frame of parameters around it. Now, some of our patients, again, exceed that 6 months, and some of us come on for a very short time, even as little as minutes. They've come to us very late in the disease process, and we admit, and then they die very quickly. Our primary focus for hospice is quality of life rather than quantity of life. We really embrace where a patient is. So we don't give up. We don't take everything away. We really focus on what's best for that patient at the time to keep them most comfortable. So some of the myths about end of life and or hospice are that when you come on hospice, you have to stop everything. I have to stop my blood pressure. I have to stop my vitamins. I have to stop my therapy. That's not always the case. We really focus on what is best for you at that time and what your body can handle. So my example for that when it comes to medications and stopping things are, maybe someone's been on high blood pressure medicine for the last 10, 15 years. At this stage in their life now, they don't need that high blood pressure medicine because they don't have high blood pressure. It's being managed. That process of a certain diagnosis can actually fade away as your body changes. Your lifestyle has changed potentially. And so you may benefit from not having it because that's one less thing your body will have to break down, that blood pressure medicine, where we would rather it break down the medication you need to keep comfortable. Again, it doesn't mean you have to stop it, but it may be in your best interest for your comfort level to stop certain medications. You know what? I don't know how to change on this. Oh, there we go. So there are thousands of different hospice diagnoses. So some of the top diagnoses that we see are congestive heart failure, COPD, which is coronary obstructive pulmonary disorder, so with the lungs as well, cancer, end-stage renal failure, and dementia. So I think a lot of people, when they think hospice, they automatically go to cancer. So there's no specific cancer diagnosis that's number one or the most. It's all of the cancer diagnoses put together. So there's thousands of them. Ones with probably don't even have names yet. But the idea is that there's many different diagnoses that make someone qualify for hospice. These typically are just the most common ones we've seen, such as Alzheimer's, dementia, the CHF. And a lot of time patients have multiple diagnoses. So they may have lung cancer and COPD, or they may have CHF and dementia. So we look at the whole picture of everything that's going on with the patient at that point. Things to watch for, some people or some patients may have had a diagnosis for a very long time. They could have been diagnosed with dementia 5 years ago, 6 years ago. They could have been diagnosed with CHF or COPD years ago. But the idea is that they start to see a decline. The disease is starting to take its natural course, essentially, and you'll start to see that decline in that patient. So it's always, sometimes it's a little things that paint the big picture. So things such as, has that person lost weight in the last couple months? Have we stopped eating as much? Do we not have an appetite? Are they playing with their food rather than eating their food? Do they need more assistance? Before that they would feed themselves, now they will not feed themselves. They want someone to feed them. Are they just saying they're not hungry? That's okay. So we never force feed, we just encourage feed. We encourage pleasure feeding, and things that be supportive that, again, make them comfortable. So it's looking at those day-to-day things that are changing throughout someone that really tell us that there is a decline. So things that are gradual. And sometimes it takes an outsider to recognize things, because if they're so gradual with a caregiver taking after their loved one, their mom, their dad, their husband, their wife, because it's so gradual, they think it's the new norm. And sometimes it takes the daughter from out of town to come and say, you know what, dad really hasn't been, I'm surprised that dad's not eating. This is dad's favorite meal and he's not interested. So sometimes it really takes a person from the outside to kind of give that nudge or to recognize it. Because again, if you're the caregiver, you're seeing them every single day. It may become your new norm for them. So always kind of keeping out for, again, the little things that make the big picture. You may start to notice their behavior changes. They're a very social person and now they don't want company, or they're sleeping a lot more, or they're sleeping a lot less because maybe they're just irritable or agitated. Decreased interest in things they used to like to do. They're a huge Cubs fan and now they don't want to watch baseball, or they were a big sewer and now they're noticing that they can't sew. So again, it's back to your day-to-day stuff that maybe really may make you recognize that they've had an overall decline in their condition. Other things you may see, recent medication. Say someone had a fall and they went to the doctor and we changed medications, but you're not seeing improvement, or the medications appear to have made you worse. We need to recognize that. We need to take a big picture and look at everything that was prescribed versus what someone's having versus what someone else having. And really, again, maybe Dr. Smith in the ER prescribed something that he didn't know that Dr. Jones already had the patient on, because those doctors may very well not talk, right? Because maybe they're different offices or the hospital's not affiliated with that patient. So we really just want to recognize what doctors are giving what, and a change in a medication can really actually make a change in a patient's condition. So we want to recognize, again, what's best for that patient at that time and take a look at the big picture and not one specific diagnosis. So an example for this is if you go to a heart doctor, he's only looking at the heart. He may not know about he may know about the lung cancer, but he's not treating the lung cancer. He's treating your heart condition. So those doctors don't always have that conversation where we look at all the things that all of the doctors are saying to really help find what's best for that patient at that time. Frequent hospitalizations are a big flag for us, essentially. Like if they're going back to the hospital more, they're falling more, or they're having more urinary tract infections, that's telling us that something's going on in the body, and we start to see the frequency in that. So one of the things we look at for hospice is, when was the last time they were at the hospital? They've been 3 times in the last year, and prior to that, they hadn't been there in years. So that's a pattern we're seeing. We want to work with that and see how we can keep them out of the hospital. Because for most people, it's very important to stay out of the hospital. And that's one of the main goals that hospice does, is we care for you at home so you don't have to go to the hospital. Again, family really sees that decline. Again, as a caregiver, it may be gradual for you, but the daughter or the son from out of town come in and they see that and they bring it to your attention. It's a good opportunity to talk things out. I hadn't really noticed because it was just a little bit less than yesterday, but then it was a little bit less than the day before too. So it always comes back to sometimes that extra set of eyes. Maybe that hospice nurse is recognizing it. She's already been in the home and she's notices it over her stay. So a patient's been with us for a month and they really start to notice that decline even within that month or, few weeks. Added concerns, someone was transferring on their own, so they were able to get to the bed, to the wheelchair, or the wheelchair to the bathroom, and those become more challenging for them. Things that they used to do, like brushing their teeth every day, twice a day, 3 times a day, that's a challenge for them. Again, back to more falls. Falls are usually a trigger that something is going on with their balance, or there is an infection. Loses desire to shave, comb, hair, brush teeth. So those are again, our normal things that we do every day, but they may become more challenging for someone. Increased incontinence, they're wetting the bed or they're not making it to the bathroom in time. That again could be something that's leading from another diagnosis. And then also it's very common for the body when it's going through the end of life stages to break down. So you're more susceptible to get bed sores or to get sores or to start to bleed. We notice it a lot on our extremities, like your heels, they just get thinner and then more sensitive to the breakdown piece of things. The hospice team is made up of more than just the nurse. So when you have the hospice come out or to your home or to a nursing home or a facility, we have a whole team that becomes part of your care. So it starts with the medical director. Everybody is allowed to keep their primary doctor or their specialty doctor. We're a doctor in addition to that. So we will have a medical doctor that will say, yes, this patient is eligible for hospice, or no, this patient is not eligible for hospice. So there may be some things that trigger us to think that there is a decline, but the doctor still has to agree that it's 6 months or less to make that qualification or that eligibility. You'll also have a routine case manager. We do our best to put our nurses in homes that they're familiar with or the area they're familiar with. So all of our nurses have their set patients that they go and see weekly. Of course, there's nights and weekends where there's, on call that may come out. But for the most part, all of our staff is pretty localized to the community. So whether it's by town or some of our rural areas, it's more of a county because there's a small distance.
So the routine case manager, approximately how many?
Everybody's different. That's a great question. Oh, how many patients do they have each? It ranges. It depends on where they're at because, rural patients, if you're real rural, you won't have as many because there's so much drive time for them, but anywhere from probably 12 to 18, again, because some of our patients may all be in a nursing home. And so there's no travel time for that nurse so she can see more patients. But that's a really great question. No one's ever asked me that. But the beauty is that's typically your specific nurse that comes out, and it's individualized care. So it's really based on what's determined as the need. So some of our patients, maybe a nurse comes out once a week because they have their routine, they're making sure that their medication is managed and they're comfortable. And they may call every now and then at night because there's the nurse was here and she said to do XYZ, but I forgot what time she said to do XYZ. So sometimes it's just a reassurance call that we do too. Some patients are seen by the nurse 3, 4, 5 times a week. So it's really based on the need that Medicare puts parameters around on how often the nurse comes to the home. I would say the most average is 2 to 3 times a week, though. That's kind of the norm for us, essentially. We also have certified nursing assistants that make up the team, and they come out and help with personal care. Sometimes they come out with the nurse if someone needs extra support, or sometimes they come out separate. Again, the average for them is about 2 to 3 times a week as well. We have a social worker who can help with any type of dynamics that you have. Oftentimes we know that sometimes it's much more emotional than it actually is physical. So that social worker is there to not only help the patient, but the family and the caregivers as well. So sometimes it just may be additional support that the social worker can help find additional caregivers or Meals on Wheels. There's things in your community that social worker can help bridge the gap to you and them for part of that. And sometimes it's just a social visit. Our patients look forward to company. So that piece is there for them. Yeah.
As the caregiver, and there's some questions or concerns. Caregiver contact your team. I can't even think of a scenario, but something changing or different or.
Oh, so with the person you're caring for? Yeah. So you would call hospice 24/7. So you would call us and we would either send someone out or guide you over the phone on what to do. So it may say, we have a nurse en route. In the meantime, we want you to administer morphine, or we want you to administer Xanax, or we want you to turn the patient or raise the head of the bed. Things like that we can guide you through as we're en route. Again, most of the time, we actually don't even need to send someone out because we can usually triage that or discuss over the phone. Oh, you know what? You can still give 2 milligrams of this. Or have you tried this? Increase the oxygen. But then again, we can always send someone out as needed, and that's 24/7. That will not be your routine case manager, but it'll be a nurse. Okay. We also have chaplains that are all non-denominational, so we can support the patient where they are. So we find that, or we hear a lot, that maybe patients that weren't religious in their earlier years have gotten this diagnosis and have found a different path. We can support that. We have patients that choose not to have chaplains. That's okay too. We're not here to judge. We're just here to support for where the patient and the family are. Sometimes the patient will decline a visit, but the family will welcome it, or vice versa. Okay. So no, it's really kind of a package deal of supporting the patient and the caregivers and family as well. We also have a full team of grief support counselors. So we have already started the process of talking about how can we help you when your loved one does die. We want to make sure that we're still there for you. We offer free grief support to the community, regardless if you had someone with our hospice or not. You just have to call and express your need, and we will set something up. We can do Zoom meetings, we can do group meetings, we can do individual meetings. So know that you have that option as well for that support. So we talked about hospice, right, as end of life, and that was the keyword I use with hospice is for someone that has a terminal diagnosis. So that, again, it's back to that prediction of 6 months or less. Does anybody have any specific questions about hospice before I talk about our next program? Is there anybody in the chat box, Megan? Okay. And again, if you think of something when I leave or trigger, I'm going to leave my information with Megan that you can reach out to me directly. Okay. There's also another program that we call serious illness care, which you may have heard previously as palliative care. Yeah. So some people still call it palliative care. We've changed the name of it, or we had changed how we refer to it, I should say, because we feel like it's really lumped together with hospice in a community's mindset. Because oftentimes they'll be at a hospital and they'll start palliative care in the hospital. And the hospice word, frankly, just scares them. And so they pick palliative because it's not hospice, but they really, really need hospice. Okay. So when you look up palliative and it defines it, it's for someone that has a serious illness. And remember, hospice is someone that has a terminal illness. So that's the distinction of it. Now, there's different types of palliative and serious illness programs. Some are hospital-based only. Some are physician-based only. We are community-based. So we can provide serious illness care anywhere. It can be in a hospital. It can be in a nursing home. It could be someone that has home health and someone that has skilled nursing. We use it as a conjunction. So it adds on to something else that you're already getting. Hospice is billed to Medicare Part A and almost all insurances. Hospice is Medicare Part A and almost all private insurances and Medicaid. And then Lightways will never turn anybody away based on their inability to pay. So even if you don't have insurance, we will still cover your care as long as you're eligible under the Medicare standards. So hospice, Medicare A. It doesn't go in conjunction with anything else. So you wouldn't have skilled nursing and you wouldn't have home health, you would have hospice. If you have serious illness care, palliative care, that's billed to Medicare Part B. So that's why it works beautifully with other programs such as home health or skilled nursing, or you're going to your oncologist still. So it's a consulting service actually. So it works in conjunction with other things. Okay. Yeah, that's okay.
A little bit slower. You just said home health care, skilled nursing, and then something else.
Oh, if you're going to a specialty doctor or getting treatment such as chemotherapy or radiation or dialysis, and all of those people are billing Medicare Part A, you can get serious illness care in addition because it's going to bill Medicare Part B. So there's no competition for any other services when someone is on serious illness care. So the point of serious illness care has a few reasons. It's really to provide pain and symptom management, because we want to focus. Someone has to have a symptom to manage to be on serious illness care, palliative care. So that could be pain, that could be respiratory, it could be agitation, it could be nausea. So a great example of nausea is someone that is going through chemotherapy or radiation. The oncologist is going to manage the cancer or treat the cancer. We're going to manage the nausea that comes with it. Or if you're maybe a dementia patient, the practitioner is going to treat the dementia, and we may treat the agitation. So there's got to be a specific symptom for us to manage. The serious illness care program is nurse practitioner based and social worker based. We come to you. So you may find a palliative or serious illness patient in a nursing home. They could be in a hospital. They could be in a skilled nursing facility, or even assisted livings and memory care units. We have a lot of patients that we see there. We really support where they're at and how we navigate their care. So like I said before, sometimes doctors don't talk to doctors, because they're in different practices or they have different specialties. Our goal is to really be in communication with all of the doctors, because it's all going to be in front of us. We're looking to see what your cardiologist is doing. We're looking to see what your pulmonologist is doing or your primary doctor is doing. Those doctors may not do that, and not for any bad reason. It's just not a natural conversation, because again, the cardiologist is treating the heart. The oncologist is treating the cancer. We're looking to manage all that. Maybe the cardiologist has prescribed a medication that the oncologist didn't know about, and that's why you're nauseous. It may not actually be the chemotherapy or the radiation itself. It could be a medication you're on triggering something. So when the nurse practitioner comes to your home, your environment that you're living every day, those doctors don't get to see that either. And so they get to see what's in front of them, and they can help guide as a plan. We're not looking to replace or compete with the doctor. We're looking to help them. Yeah.
How does the family become involved with palliative care? You said how it became involved with the
Hospice?
yeah, hospice.
Yeah. So the main difference with serious illness care is it's much more limited than hospice, because it's not for someone that's terminal, it's someone for serious. So with a terminal patient, staff is coming out weekly. With serious illness care, that may not be the need. A nurse practitioner may only come out once a month, because she's there to manage that specific need. He or she may come out 2 or 3 times a month. It's all about the need at the time that they're managing. Some patients improve because their medication is managed. They're able to function their normal way that they were before. So they may take a step back from serious illness care, or they'll discharge from serious illness care. Some may get worse because it's natural. It's a natural part of the disease. They've exuded all of their treatment options, and they know that nothing they do, or they're not a candidate for surgery, or they're not a candidate for more chemoradiation. They may eventually come to hospice. So it's all based on that specific individual, what they need to stay on serious illness care, to come off of serious illness care, or to go to hospice. Do you have a question?
Yeah. Long time ago, it was called geriatric care. I don't even know if that's in part. Are you kind of in that realm?
So geriatric care, or like a geriatric physician, is really just a specialty physician. And really, you could be on hospice at any age. So the majority of our population, I would say, is in the geriatric care range, but we actually see pediatrics as well. And we're seeing a lot of a younger population between like that 30 and 50 mark of very rare cancers, and very rare just diseases in general. So there's no age limit to being on hospice, but there are still geriatric physicians practicing for geriatrics, but we cover all ages. Again, on here it says Medicare Part B. It also is covered by most private insurances as well as Medicaid, but Medicare really sets our standards of eligibility, and then most of the private insurances and Medicaid follow suit on what makes someone eligible. Excuse me. So just a little bit about hospice versus serious illness care, because I think when we compare the two, it's how we kind of understand each of them. Hospice is that 24-hour service where you can have availability. We can send a nurse out, we can send a social worker out, we can send a chaplain out. We help with, funeral arrangements essentially, or the planning of things. Where serious illness care is more of a, again, remember, because it's nurse practitioner driven, it's more of an as need and scheduled. So you can still call and say, you know what, I've seen a decline or we're out of medication. But for the most part, the serious illness care is a scheduled routine, and it's not 24/7 like hospice is. But it's still a great resource. One, to keep the primary reason Medicare created the palliative benefit is to keep people out of the hospital, because people are going to the hospital for things like a fall, but we're having a fall because there was a UTI or there's a change in a medication. So this helps them stay at their home because we're going to come to you and manage it then before it gets too bad and the ER is your only other option. So the idea is really to manage a symptom and keep you out of the hospital. To keep you out of the hospital, serious illness care or palliative care is. Yeah. Is there any questions of serious illness care? We also do offer other options, like I talked about our grief support team. Anytime a patient dies, we follow up with that family for 13 months minimum, because we want to make sure that we hit all those first Mother's Day, first birthday, first Christmas without their loved one. So once a patient dies, our care does not stop for you. And like I said, too, majority of our patients choose that, to have that one-on-one. They make that relationship with the specific counselor. Sometimes there's small children in the home, so we actually have counselors that are specific for children, or we have grandparents raising grandchildren, and so we want to make sure that growth process or that journey is available to all of them, regardless of their age or whether they were living with the patient or not. But again, you do not have to have Lightways Hospice in order to use our grief support. So you would just call and make an appointment and we would support that. And we do a variety of different things. We do groups. We had a Mother's Day tea. We do a youth camp for kids that have had a loss. So there's any age or style, typically we can cater to that person's needs. We also try to do a lot of proactive education with healthcare power of attorney. So we can actually help you with your healthcare power of attorney. And I'll give some examples. And actually, it's a personal example. I'm an only child, and both of my parents are deceased, and I have no living grandparents. I have two amazing aunts in my life, blood aunts. One I'm close to, and I see her on holidays. One I haven't seen in years because she lives out of state. I love my aunt that's good to me, that's close to me. But me and my aunt have very different beliefs. We have a different religion. We have a different way of thinking, from politics to what color my hair is. And so, although she's a great person, if I did not have a healthcare power of attorney in place, she is who would be chosen for me based on next of kin. So I always express it's very important for you to pick the person that will make the decisions on your behalf, not on their behalf. A lot of times our families or our patients will say, oh, it's my oldest, I got 5 kids, my oldest daughter will make the decision, or my oldest son will make the decision. But would your oldest daughter or your oldest son make the decision how you would want them to make it? So you need to pick the person that will follow your wishes. And it sounds like it's a difficult conversation. And I know that it's easy for me to say because I do this for a living. But oftentimes, or the majority of times, the person you pick will welcome it. And they'll be happy that you're telling them what they want or what you want, so that they don't have to second guess a decision they made. So we think that conversation may be awkward or uncomfortable, but it's better for them to know now rather than in a critical situation. So you say, Sarah, I'm picking you because I know you'll respect my wishes, and I trust that you'll be my advocate. And I want you to know that now, that I'm picking you because I know that I can trust for you to do that. Then I think it's also important for you to tell John that you picked Sarah because you feel that she would respect your wishes. So then in the critical situation, there's no questioning on who is making that decision for you. And it's a simple paper and a simple form that you can do. You do not need an attorney. We don't do financial, or we don't do wills, we focus on healthcare power of attorney. I also suggest that you update it because it can change from time to time. For example, you may have your spouse and you outlive your spouse. So you want to make sure you have an updated one. Worse, you could get divorced. And now you have your ex, because it's on that healthcare power of attorney, and now they're making your decision. Well, that's why you got rid of them, right? To not have to make any decisions together. So we always encourage to have that conversation, keep it updated. And it may seem awkward, but I'm willing to bet 9 times out of 10, they will welcome that, so that if they ever get in that position. I made mine when I lost my father when I was in high school, and my mother died when I was in college. And right away I was encouraged. I had a friend that was an attorney, and she said, make this now, do this now. And I made a decision, and it was the right decision at the time to do my healthcare power of attorney. It was my childhood best friend. I would rely on her. I could trust her. Then she lost her brother. Her brother died. And I saw what I felt is that she didn't respect she was his power of attorney. And I felt that she thought from her heart and not from his wishes. And that was a reality for me, because I think she had the best intentions possible, but it was her intentions essentially and not his. And so I changed it. And I changed someone that most of my friend circle probably wouldn't have pegged me to pick, but I know that she will stand up for what I want, and more importantly, what I don't want. And so I had the conversation with my friend, and I explained to her why. I just thought, I'm just nervous that you would have a challenge to support my wishes. And she said, I would. And now I know that I would. And then I told my friend, and I told her who it was, and this is why I picked her. And it hasn't come up since. There's no hard feelings. So it's always easier to have a conversation when it's not a crisis time. Because if you do not have this in writing, it will be chosen for you and it's next of kin. So, and there's sadly, what we'll call there's a pecking order. There's an order in which it goes into. So it defaults to a spouse, and then it would default to all children. So not the oldest, not the youngest, not the boy, not the girl. It's getting all of the children together and agreeing who will make that choice. Now, I know there's some close siblings out there, but there's some very different siblings out there, right? So imagine you're at a critical point in your life and your children are fighting over something. We could eliminate that conversation, right? So you have, again, your children, and then it goes to parents, maybe. Then after that, forgive me, I'm kind of going off the top of my head now, all the way down to neighbor. If you're not married and have been with your significant other, regardless if it's been a year or 20 years, it still goes through that pecking order. And so we have a lot of patients that have been with their significant other for 20 plus years, but they have kids from a previous marriage that it may or may not be in the picture. That caregiver and that significant other has no say until those kids default everything. So that's why always the education is really knowing your options. You may not need hospice now. You may not know anybody that needs hospice now, but I guarantee you know someone that needed it and didn't get it. And I also guarantee you probably knew someone that had it. And the one thing that we hear the most at the end of life is, I wish I did this sooner, but there was a stigma, or we weren't aware, or the diagnosis came on too quick, or we wanted to try all these options. So that's why the best part is at least know it's an option. Have these conversations, and then you can move forward that way. Same with serious illness care. Not everybody is eligible for serious illness care. But if you're having a symptom to manage, call us. We can come out and determine that. We come out every day, and there's a lot of people that, one doctor says, yes, I think you're eligible for hospice, but then our doctor disagrees. That doesn't mean we can't come back tomorrow or the next day. There's no charge, there's no bills. We focus on where you are right now and try to go from there, whether that's hospice or serious illness care, or it may be neither. Yeah.
Well, that's a good question. So a doctor has to certify that serious illness care. And
No hospice. You have to be certified for hospice with a terminal illness.
what about serious illness care?
No.
By the
Nope. No, but you don't have to be terminal for that. You have to have a symptom to manage for that.
That's what I'm saying, but so a doctor has to be able to say the symptoms. Mild Medicare come in.
So we would get a doctor's order that this person is eligible, appropriate for palliative or serious illness care, but then our actual doctor is who follows the guidelines to ensure that they are eligible. So sometimes we have doctors that disagree. It's pretty rare. It's pretty rare, but yeah, there are some instances, but you do not actually have to be certified with the terminal illness for serious illness care, only for hospice.
Yeah, I just meant certified just that it's.
Oh, no, you would just speak with your specialist or doctor and say, and a lot of doctors may not know that you have this resource in your community, or they may have their own set in their ways, let's say, or their own religious preferences. Because I will say that hospice and serious illness care, if you ask a doctor if they learned about it in med school, they'll say no. And if you ask a nurse, they'll say it was one chapter. And so they may just, one, be uncomfortable having that conversation, or two, it's just not part of their scope. That's a good word. Yeah. So some of our challenges, we're very fortunate to have amazing doctors, but some of our challenges actually educating the doctor, because they're uncomfortable having that conversation, or they think the family doesn't want to hear it. So let's make them feel comfortable while they're in the doctor's office. And 9 times out of 10, a doctor will admit that, so I don't want to feel like I'm not bashing physicians at all. We need them amazing. But the idea, sometimes I think they rely on us to have the conversation every day, every single day. We're in 4 very large hospitals, and every single day, at least one patient, we'll meet with them. We'll go through everything on how we can help them. And they'll say, I'm waiting to talk to the doctor one more time. They've called us. That doctor's not coming back in the room to talk to them. And so a lot of people delay starting hospice because they're waiting to talk to the doctor, or they want a second opinion. Or they're, but it's like, all right, if they've called us, they're likely not coming back in their room because they've now handed the conversation off to us so that they don't have it. Or they present it in a way that maybe they don't call it hospice, or they'll call it comfort care, or they'll call it palliative care, when really we're coming for hospice. Is there any other questions? I can talk for days, so you guys.
When you said that the doctor will call for comfort care, but really in mind is hospice. So, then what's the patient's mind and then the family's mind? Maybe sometimes start out with palliative and then progress.
Absolutely. So I did said earlier, sometimes patients will choose palliative purely because they know they need help, but they don't want to commit to hospice or admit that that's where they're at. So they may start it. They may be on it for days, weeks, months, and then transition to hospice because their disease process is following that path. They see that there's no improvement, where the focus would just be comfortable with dignity. Because in hospice, we are not trying to fast forward, and we're not trying to rewind. We are walking alongside of you with where you're at right now. We're managing now. We're not managing yesterday. We're not managing tomorrow. We're managing now for you. Yeah. Yeah. We really want to focus on it. And well, where we go to all of them, but I would say like Silver Cross Hospital, St. Joe's and Joliet, Morris, and Amita Bolingbrook, and then we come to Rush Copley as well. But we will come into the city to meet a patient wherever they are, because we're going to bring them home, right? And when we bring them home on hospice, we're going to arrange everything. We're going to get transportation. We're going to get you a hospital bed. We're going to get you a wheelchair. We're going to get you action. Anything that you need to go home safely and comfortable is covered with that hospice piece. Not every patient needs that. I don't want the hospital bed. I want to sleep in my own bed. Okay. I need the hospital bed because I need to raise the head of the bed. Also okay. I don't need oxygen now, but I may later. Okay, we can do oxygen later. So we could have all those things in place before that patient ever comes home from the hospital. But we go to all of the hospitals. So there's actually in Illinois hundreds of hospice companies. So that also goes back to knowing your options, because a hospital or a certain physician may work with a special hospice group, but you have the option to pick the hospice that you want. Same for serious illness care, just like you have the option to pick what doctor you want. So keep that in mind too. Because there are a lot of hospital affiliated hospices, like XYZ hospital owns XYZ hospice. So they use that hospice only, but you always have a choice and a right to pick a different organization. So again, back to kind of knowing your options before you need them. And you can be clear, of course, I'm going to say you want Lightways Hospice, but you may have had a family member that was with another hospice and you want to stick with them because that's who you're comfortable. Okay, so you need to vocalize, I want hospice XYZ or I want hospice Lightways.
How many hospice organizations are there?
Way more than 10. So there's for-profit and non-for-profit. And then each hospice has to be licensed in a county. So when I referenced to, we got our start in Joliet 40 years ago, we've expanded to all of the counties around us as well. So all 11.
So what's the difference between profit and not-for-profit?
Your mission typically. So what I can say about us as a non-for-profit, we're non-for-profit. We're board operated, so there's no financial gain for anybody. It's the, yeah. So a board, we go through a board. There's no stakeholders. So our decisions are driven purely on what's important to the patient, not what's important to financial situations. So we do a lot of fundraising throughout the year. We do all different types of things, anything from golf outings to garden walks. That helps us pay for our patients that we do charity care for, because we will never turn anybody away based on their inability to pay. We also have a freestanding inpatient unit that's located in Joliet, formerly known as the hospice home. We call it inpatient unit now. And we have 20 beds there. And those are for the highest level of hospice care patients. It's called general inpatient. So if someone has an extreme pain or symptom to be managed, we can bring them there and manage them. It's a home-like setting with hospital equipment, if that makes sense. So we have high levels of oxygen. We can do vent removals. We have a doctor that rounds every day. We have a nurse, skilled nursing care that's throughout the day. We have a social worker, a chaplain that's available to the community, but it is the highest level of hospice care, and not all patients actually qualify for it. So it's a case by case, again, day by day situation, but we do have that resource as well. And our patients from any of the 11 counties can come to that if it's in Joliet. Yeah. Of course, we welcome all family. Every patient has their own private room with their own private patio and doors that open with their own bathroom. And then they're welcome to stay. We have a pull-out couch. We also have, of course, yes. Yep. And then we have a full staffed kitchen so that the family can eat with us. We also have a family kitchen where the family can come and cook for their own. And we were the first freestanding hospice home in Illinois. And we were the first freestanding hospice home to increase the beds from 16 beds to 20 beds. And right now we're the only hospice home with 20 bed availability. And we do run full most of the time. Yeah. Anybody have any questions? And again, safe zone. So please, if you want to ask me something on the side or reach out to me, I really do welcome that.
I don't have any questions, but I do have some online. Thank you for coming and saying that you are one of us here.
Oh, thank you. I'm an only child, so I always welcome attention. Yeah. And yeah, we do too, but it's really about patient choice and individualized care. So you may be on hospice and your neighbor may be on hospice, and you may have the same diagnosis, but your care could be very different because you have different needs at different times. So that's why we always focus. The big question is, how many times are they coming? It's like, well, we have to determine that need because everybody's going to be individualized care. One patient may be allergic to morphine, so they need something else, so we really focus on what's best for them, again, in that moment. Some we may come into a home and realize that this caretaker or this spouse cannot take care of this patient. It's not safe for the spouse. We can help find placement. So we actually work with about 45 different facilities, nursing homes, assisted livings, memory care. We can help find placement too. Well, no. So we help find that placement, and then it's either private pay for the room and board for them, or Medicaid can cover the room and board as well. Medicaid. Yeah. Or it may be, you know what, I can successfully care for my husband at home, but I need a break once a day. So there's private caregivers that we can resource you out to that may come 4 hours a day. We
Recommend private caregivers. Is that what you're saying?
we suggest, we don't necessarily recommend, because we always want to make sure you're picking. There's no gain for us on who you pick. We want you to pick who best fits in your house. So when I go out to meet a family for the first time, I say, here's a list of places our current patients have given us positive feedback on. Because everybody's different, right? You may like a company that I had a bad experience with. It's like going to a restaurant. You may love Chili's. I don't want to go to Chili's. You know, it's that simple. If you have to do what's right for the environment, you got to pick the right caregiver. They're in your home. That's your personal space. So we say, call 2 places and see who you have the best feeling with. So again, it comes back to choice and knowing your options at that point. Some people have live-ins, you know, there's everything from 4 hours a week to a live-in and all different price ranges too. So that's not my niche to speak for because it's individual based on those organizations that how to do that. But we definitely can guide you in the right direction for what's best.
Thank you for lots of good information.
Yeah.
Very good. That's a lot of things to start. wheels turning.
Better to know now than again in that need.
When you put more into it.
Going back to the beginning when I said there's a new diagnosis, or it's, you know, that it's very new and you're not sure what the prognosis is. Is it something that's treatable? It's not treatable. Is it a risk to treat it potentially? Or maybe it's an old diagnosis that someone's had for a while, but you're noticing those declines. Appetite, weight loss, falls, and going to the hospital are probably the top 4 that I would say are triggers that a conversation, open the door for a conversation. Yeah. Weight loss, loss of appetite, falls, and frequent hospital stay, you know, back and forth to the hospital. And then too, another one thing is just sleeping more or not sleeping, you know, with dementia patients. A lot of them have sundowners. I don't know if you're familiar with that, but it's when they're up during the day or sleeping all day and then up all night. And that's a new pattern for them. Not everybody with sundowners is eligible, but it's a change for them. I'm noticing a change. They've had dementia. I've noticed confusion for years, but now I notice they're not sleeping or they're not eating or they're playing with their food or their behaviors change. You know, they went from the happy person with dementia to what can maybe appear to be the mean dementia, maybe vice versa. You know, so you're noticing the change or a decline in their condition.
Yeah, I can see where many people would not be reaching out because we're living with the person and then new changes are normal.
Yeah.
You gotta adjust to it.
And some people don't want to share with others that there is a decline too, you know, and really we're just going to bring that help in for you. And more times than not, I said it before, more times than not, we hear, we wish we did this sooner. Or he's so much more comfortable. That's where we see regret, essentially.
That's great feedback too.
Mhm.
Versus uncomfortable.
If I ever got a TED talk, it would be about I'm not ready. That would be what it's called. So no one steal that, but it's I'm not ready. But you're not ready for what? You're not ready for a nurse to come to your house. You're not ready for equipment to come to your house. You're not ready for on-call staff 24/7. What are you not ready for? To say the word or admit the word or to get the care?
All above.
Mhm. And hospice 20 years, I mean, heck, hospice 10 years ago, you know, it was, you know, people may think it was clinician driven. You know, you give morphine for pain and they come and hold your hand. We have evolved so much since then that we have so many options. Some of our patients even still get physical therapy. because they want to maintain. They know they're not going to run the marathon, but maybe it's important for them to be able to get from bed, to have breakfast with their spouse, or to have a cup of coffee, or to brush their teeth. And so if a little bit of therapy helps with that, just to kind of keep the muscle movement, things like that, we'll support that. We'll support it. It's not about giving up. It's about embracing where you're at with comfort and dignity.
How long have you been with Lightways?
I've been with Lightways, it'll be almost 6 years. And then I was with another company for 4 years prior to, but I've been in healthcare for 22 years probably. So Botox does good for me. So I look young, right?
Yeah,
Most
lots
of
of
the time it starts in the home.
Most of the time, yeah. We're at the hospitals a lot because it's that patient that's sudden, or they waited to the very last minute to go to the hospital and it was just too late. They've been put on a ventilator, there's no prognosis. And so we get a lot of patients at the very, very end stage of their life and they come from the hospital. But we have, just maybe this will help with the frame of mind, we have 400 hospice patients right now, 400. And I would say about 275 of them patients are in their physical home. 15 to 20 are in our hospice home. And then the rest are maybe in nursing homes or skilled nursing facilities.
So over half are in their own home.
Yeah.
That's
We have 2 types of patients. It's very important for them to die at home, or I do not want to die at home because this is where my spouse will reside, or my children, or I don't have the care. So most people have a decision one way or the other.
interesting.
Mhm. Or they're unsure because they don't know what their family wants.
But and then again, I think it looks at cultural society.
Mhm.
40, 50 years ago, people died in their homes.
Absolutely.
Women dying in the nursing home is.
Yeah.
People now think that's normal.
And I would say more times than not, the patient accepts that they're dying long before the family does. In a previous life at another company, it was I used to go out before I was a director and I would meet the family for the first time. And so I'd go through the consents, what's this going to look like? And I would assign a nurse and send a nurse out. I just got off orientation. I went and did a very rural area. And I was going to go meet this patient and her daughter. And it was my very first one alone. So, you're kind of nervous and you're comfortable, what you're talking about, but what if they throw that question and I don't know the answer and it's going to happen, and I remember like my white knuckles to that house, I'm on my own, I kept checking my phone and so I walk up to this farmhouse and the daughter greets me at the door and she says, "Whatever you do, do not tell mom she's dying."
She knows.
I wanted to get back in my car. Like I got a gear that says hospice. I'm signing her up for hospice. We know 2 things for sure. There's life and there's death, right? And I was just like, okay, all right, Mary, talk myself through this. And so she brings me to her mother or the patient in her upstairs stairs, like I'm climbing this old farmhouse. And the patient asks the daughter for water. So the daughter left me upstairs alone. And the daughter goes downstairs. The patient pulls me in by my tag, and she goes, "Do not tell my daughter I'm dying." And I thought, that show like where they trick you on things, but it was just the point, because here's the thing: the mother was protecting the daughter. The daughter's protecting the mother. You don't lose those senses, right? Or you don't lose those feelings. And it was just important if they would have had this conversation before the crisis, that it's okay, we maybe could have avoided the fear with the daughter and the fear with the mom.
And you have to navigate that.
Yeah.
Their wishes are.
It is. And it's different. It could be purely religious beliefs, cultural. The African-American Hispanic community and the Muslim community are least, I'm sorry, I haven't talked to, I have a presentation, I haven't done this in a while, are the least likely to choose hospice because they care for their own. That's their culture. That's their vision. And so they're hesitant to get that help because it's them not being enough. And so we do specific programs that target those communities that you're helping them more by you helping them and letting us help them. And so it's a huge cultural thing across the world, actually.
So
Keep them coming.
Just get back in your shoes. I mean, you could be put in a difficult position. I mean, do you try at least to get, I mean, because someone might always want to be present there with the patient. And then the patient might never be able to be free if they so wanted to be. But I think that she said she tried to get the person to get a glass of water, so that was natural.
Yeah. So if a patient's decisional, they always make their own choices. So even if you have a healthcare power of attorney in place, that only comes into effect if you're not decisional. So just because if something happened to me and I had a new diagnosis tomorrow, my friend's not going to make my decisions until it's deemed that I'm not able to make decisions. I have confusion or I'm not conscious, things like that. So I think there's a fear of that too. It's like, nope, I'm strong-willed. I'm going to make my own decisions. And if a patient is decisional, they must agree to hospice. It has to be on their terms.
Okay, but what I meant was, if I'm the patient and I don't feel free to talk because.
Like you can always ask someone to leave the room. And absolutely, that is how we specialize. You know what? Give us a minute. Let's talk some things through and then maybe we can come back together. Yes, especially if the patient is decisional, we're going to honor what they want and they need at that point. Now, with knit gloves, because we still know that that daughter needs her own support. And maybe it's the different support than what mom needs. The daughter needs to be heard. The patient just wants to be comfortable, or vice versa. The patient wants to be heard. I have a voice still. This is what I'm telling you. And the daughter's so worried about the patient being comfortable or declining medication or, choosing not to have hospice or choosing to have hospice. So yes, there are challenging times that we are put in that situation, but we really are always an advocate for a patient and we can be the advocate for the family as well.
When you mentioned that, it sounds like people know they want to die at home. Not at home. I know where I want to die at home. But
I do not. So there you go.
Yeah. There you go. Is there more of a lean one way to the other?
I would say most want to die at home. Or more so as I just want to be home. Like get me home is probably 75% of the time.
Oh, that's a big percent.
Yeah, it's a big percent, I would say.
Very interesting to hear your experience.
Yeah. My TED Talk's coming. I was just teasing this.
Well, you're working on it right now.
Yeah. I do bring it. I should have brought her to have this big stuffed elephant and we call her Ellie. So then a lot of times what I do, if it's a large group, I'll set it like in a chair somewhere and not address it. And the whole time people just watch the elephant. And then I'll say, I'm talking about a challenging or a difficult topic and you guys were focused on the elephant. And then so that maybe that'll be by TED Talk too. But it does, it brings attention. And so when we do healthcare power of attorneys, April was like healthcare decision day. So we gave out little elephants just to break the ice, like let's break the ice, like let's address it and let's move forward from it. But every family is different. Every family has their own beliefs, their own dynamics. That's the
individuals.
Yes, absolutely. Absolutely. Nothing else? It's okay. I'll talk one-on-one with you. There's no problem about that. I'll sit down here when we're done. So if there's no questions online, right, I can encourage you to, we are 24 hours, 7 days a week. So you can always call and ask for me, or maybe Megan can send my information out if they have any specific questions. And again, there's no silly question. And you may or may not be eligible, and that's okay, but we can help you go through that process. At least, again, now you know your options.